All right. So, Ahmed, you want to start, Ahmed? Or Muhammad?
Okay, Samer. I will start.
Yeah, go ahead. Start. Okay.
30-year-old right-handed woman is referred to your clinic with worsening arm pain and function over 18 months. In the past, she suffered distraction injury to the arm. She described a burning pain that radiates to the axilla, hand, and all 5 digits. Any forehead movement worsens the symptoms. The test maneuver on physical examination that is most useful in supporting the diagnosis of a neurogenic thoracic outlet is.
Okay. So they're talking about neurogenic thoracic outlet syndrome. They want to know what the best maneuver to make a diagnosis. Okay.
Okay.
Let's see what options they give us. We'll go one by one and see if it's correct or not. Okay, go ahead.
A. Auscultation of supraclavicular fossa for Browy.
Browy. If you hear Browy,
This is stenosis, and
but this is for. Go ahead.
This is for stenotic subclavian.
Okay.
It wouldn't be a sign for thoracic outlet unless there is vascular thoracic outlet.
Correct. And this is not the vascular, correct? This is a neurogenic.
Yes.
That's not correct. Correct. Next one.
Then Adson's test.
Okay.
I'm not sure what is Adson's test.
What about Allen test?
Allen test is for dominancy,
the one
ulnar and radial.
Adson test, the one doing the clinic. You remember? When you hold the pressure, the radial pulse, and ask the patient to lift
okay. Okay. Yeah. Okay.
It's called Adson. Yeah, called Adson. This is the one you put your hand on the radial and lift up the arm, you extend it, and the radial pulse will go away.
This is also vascular and not very sensitive or specific.
Okay. Allen test.
Allen test is for dominancy, radial ulnar to test the arch main supply.
Okay.
And then there's upper limb tension test by LV.
Of LV.
Of LV. I believe if we exclude the above, this should be the answer.
Yeah, this is the same. This is an extension, the same, this one. You know, you ask the patient to abduct his arm, straight his elbow, and I think dorsiflex the wrist, and then ask him to move his head to the other side, and then they get the symptoms, the numbness, you know. It's very close to Addison test. Addison test, you're looking for you put attention on the muscle. In Addison test, you feel the pulse. Here you get a numbness, you know, and tingling feeling if you do this maneuver.
Abduction?
So abduction, straight, flex, dorsiflex of the wrist, and then ask him to move the arm. So you put the most tension on the muscle here, scalenus muscle.
Okay.
So abduction, straight, dorsiflexion, and move the hand. This is usually called LV, you know. So again, I mean, this is mainly for neurological. But
okay.
Well, let me ask the more senior, like Muhammad, okay? So what the test which make definitely diagnose neurogenic thoracic outlet syndrome, or anyone, doesn't have to be Muhammad, anyone. What's a definite test to make a diagnosis? Well, make it easier. Let me give you this one. If the question came, was it definite? He said the most useful, but what is the definite test make neurological thoracic outlet syndrome? First, Adson test. Second one is ALTI, or the LV. Third one, EMG, nerve conduction compression, positive EMG study.
Not good.
Four,
no, not specific.
Thoracic, cervical rib, and fifth, none of the above.
The EMG is not. It is non-specific.
It showed a compression, like a, you know, a definite.
Yeah. Can I?
Anyone can do that.
There might be imaging consistent with compression, but not necessarily.
Yeah. You will put the upper limb in action.
Mm-hmm.
And you stress the muscles, then it will compress the nerves.
Mm-hmm.
If there is thoracic outlet, then it will give you hand. It's not 100%, but it will help in diagnosis.
Okay, all this helpful, but my question is definite.
Yeah.
This is my question.
D is, it's not definite, but D is the most correct answer in this scenario.
No, I know about this one. I'm not asking about this one. No, I agree with this one. I'm not questioning this test. This is a question. I'm speaking if you get in the exam a question exactly like that, but instead of saying most useful, they said what's it the definite test for diagnosis of neurogenical thoracic outlet syndrome, and they give you the ULTT, EMG, Hudson test, cervical rib, or none of the above. Because you have to make a surgery, you have to make a diagnosis, different diagnosis. This is all helpful. But which one?
None of the above, because you will go with if there is cervical rib, then you will go with symptoms. If the patient is symptomatic with and there is cervical rib, you will go for it. But no test will help in diagnosis 100%.
So how do you make a diagnosis to do a surgery? If we don't non-test is different. So how do you make diagnosis?
I mean physical examination, but X-ray or CT, if there is signs of compression as cervical ribs, and the patient is symptomatic, then you will go for the surgery.
Okay. Why Allen test is not? Sorry, Addison test. Why is not?
Hudson test is mainly arterial. If the patient is having arterial symptoms, which is like 1% or 1 to 3% or only in the thoracic outlet syndrome, it will not help to diagnose the neurogenic one.
Okay.
I am positive in Adson's test, Dr. Samer.
Sorry?
I am positive.
About?
Myself, positive about Adson's.
Is what?
I lose the radial pulse.
So this is, what do you mean? So is diagnostic or not?
No, and my own, myself, when
okay.
when I check it, I lose it.
How often you lose in normal people? That's how often it's positive in normal people?
I don't know.
It's higher, up to 50% people have a sentence positive. So this is useless, really. But we do it anyway, you know. So for arterial, it's very simple because arterial, you have to have a sign embolization or aneurysm, something like that. So you can make a different diagnosis in arterial. Because in arterial, patient has to have a symptoms. You know, it's like, again, like embolization or aneurysm dilatation. So it's easy to make a diagnosis. Venous is very easy also because patient comes with DVT and thrombosis. The difficult one is the neurogenic thoracic outlet syndrome, because this is difficult to make because numbness could be coming from, cervical rib, come from, from disc, for a lot of things. So unfortunately, this is no definite neurological thoracic outlet. So if you get definite, then the answer will be none of the above. We don't have a definite test for the neurological thoracic. All are helpful. We call them helpful, help you to make a diagnosis. So EMG, it helps, but it's not definite. Hudson, it helps. ULTT, it helps, but none of them is a definite. So all are helpful tests. So finally, you have to make diagnosis depend on the exclusion. So you have to exclude everything. When everything is excluded and patient still symptomatic, then you put neurological thoracic outlet syndrome as your diagnosis. Okay. So this is test by exclusion. Okay, it's the way you make a diagnosis. Okay. All right.
Samer.
Samer. Sorry. Go ahead, Ali.
Good evening. مساء الخير. مساء الخير. I used to do the EAST test in these cases. Elevated arm stress test. The EAST elevated arm stress test. We used to do this test for neurogenic. So you can raise your arms 90 degrees and you open and close your wrist for your fingers for 3 minutes. And in these cases, you can, if you feel numbness or like that or fatigue, then it is neurogenic. It's EAST. It's like ELVE, I think, but I know it like EAST. Elevated arm stress test.
Correct. This is EAST and ULTT is very similar. Yes, the way how you do it. When you do extend the abduct the hand, when, as you said, you lift it up. But even though, Ali, none of them are definite. I mean, because you can have like a cervical, you know, this can give you the same symptoms. So, I mean, yes, all are helpful,
Yeah.
but this migration is not definite. You cannot say 100%, I'm sure, you know. So are they helpful to make a diagnosis? But you have to have another reason, like you have to have like, you know, MRI saying cervical rib or like, you know, big muscle or narrow, you know, triangle or other symptoms. But neurological, really thoracic, from the very difficult to make a diagnosis. Reason why we say on exclusion, like you have this test and you do an MRI for the neck and no, you know, no disc, no compression, then yes, you make a diagnosis. But you cannot just say, okay, it's positive, 100% is neurological thoracic outlet syndrome. Correct, Ali?
Yeah.
Okay. So let's go to the next one. Muhammad, you want to take this one?
Yes, sure.
Okay.
A 21-year-old swimmer presents with progressive weakness and numbness with loose sensation in the lateral aspect of the left arm. After motor vehicle crash 2 years ago,
Okay.
his injury has progressed to the point where he has near constant numbness in all fingers of the left hand. He can no longer swim and is in danger of losing his scholarship.
Good.
Additionally, he cannot type or hold an object in his left hand for the fear of dropping them. A physical examination is remarkable for strongly positive tunnel sign
Okay.
over the left supraclavicular fossa and positive elevation arm test at 30 seconds.
Okay.
A C-spine MRI chest X-ray without cervical rib, venous duplex showed, and non-invasive vascular testing are all normal. EMG indicates sensory abnormality in the median and antebrachial cutaneous nerve. Neurogenic thoracic outlet syndrome is diagnosed. The next option in treating this patient is, so this patient, he's mainly have neurological TOS, which
Correct.
is very symptomatic and affecting his life.
Okay.
So yeah, this patient.
So they want to know what
options. Yeah.
in treating of thoracic outlet, what you should do. So you make a diagnosis, give a diagnosis, they said neurological outlet syndrome. You have EMG, you have what, as Dr. Ali said, the arm stress test, you know, positive tinel sign, like you get, you know, pain when you punch the nerve, you know, positive tinel test. So all this is positive. So now they want to know what your next step, how you treat thoracic outlet syndrome. Let's give us this option. Let's see all of them.
Okay, so A, thoracic outlet decompression with anterior scaliotomy, lysis of the brachial plexus and removal of the first rib. B, directed physical therapy. C, injection of botulinum toxin in the anterior scalene. D, injection of corticosteroid into the anterior scalene. E, referral to pain management for chronic pain pharmacotherapy. So, as I mentioned, this patient is having neurological tests with significant effect of his life and career. So they want something very appropriate. I think the surgery is the most appropriate answer.
Okay. You remember when we are doing with Dr. Amran, you know?
Yeah.
He said you should not do surgery unless you exhausted all your physical therapy.
Yeah.
So this is a problem, because I tell you why. Yes, the surgery will solve. The problem is the improvement with surgery only like 50-60% really, you know, even if you realize all the things, you know?
Yeah.
Because it's not like pure compression, because you have a stiffness and you have muscle spasm, you know? So really physical therapy is very, very important. And most of the time, the people just improve by physical therapy, you know? And the same, like if you have a herniated, you have a disc, you know, back pain, a herniated disc, and you cannot walk and very spasm, most of with physical therapy, people improve, you know? So all neurological have to try be aggressive physical therapy. Really, we don't do surgery for thoracic outlet unless if patient failed physical therapy, you know? So this is even with this pain, with this guy, even this one is guy better because you don't cut his muscle, and you know he's a swimmer. He's so you try with a physical therapy. You usually try for 6 weeks. If he improve, you continue. If it doesn't improve, then you can try something else. So I think physical always has to be first line. You cannot patient take surgery without doing physical therapy in thoracic outlet. And second thing, even after surgery, remember when we do our thoracic here outlet, we always send them for physical therapy after surgery. Used to physical therapy from the beginning. It's like a weight loss, surgery. You don't take patient weight loss surgery. You have to go through a long term of medical weight loss before you go to surgery. And here, very similar. So always you have to start with a physical therapy. So surgery only for failed physical therapy after at least 6 weeks, 6 to 8 weeks. Okay.
Okay.
So yes, thoracic outlet will give you, but it will not our next option. This is one injection of Botox. It's very helpful, and it works already for 6 months. But again, this is like temporary. Make you sometimes to make a diagnosis. Cortisone, I don't think that will work. The anti-scariness. Pain management, chronic pain pharmacology. This is like I think for maybe chronic cases, maybe after surgery you still have pain, it's for pain management, but will not be your first option. Okay. So again, thoracic outlet, it doesn't matter how bad it is, always start with a physical therapy. Okay.
Okay.
All
because he put a very long scenario that is the case is very bad, and it's misleading.
I tried to push you that you be aggressive, and with this guy, and he's young and swimmer. No, you'll be surprised how much people improve. It's about, I think it's about, also maybe 70–80% really they improve, The majority they improve only in physical therapy, So surgery is not the best option because again, they get adhesions after surgery. So there's a lot of high chance of recurrence, And some people, they not improve, So I think physical therapy is the best way to go. Yeah. All right. All right. Let's go to next. Who is Bassam?
Yes, sir.
Number 3. So all neurogenic thoracic outlet.
Yeah, because it's the most common type. A patient with neurogenic thoracic outlet syndrome attends 6 weeks of physical therapy. He returns to your office with only minimal improvement. He is frustrated but not sure about surgical decompression. He asked about other non-operative treatment. The non-operative therapy to be considered in this patient is neurogenic thoracic outlet syndrome after physiotherapy. He's asking for other options than surgical.
Okay, let's see what options they gave you here.
So referral to pain management for placement of spinal stimulator. Referral for anterior scalene lidocaine injection. Referral for botulinum toxin injection of the anterior scalene. A 6-week trial of corticosteroid therapy, radio frequency ablation.
Well, let's start one by one. This is our first one.
Pain management is a good option, but if there is cervical rib, I don't think it will work.
I mean, always pain management is the last option, Like patient with a critical ischemia, come to you, don't stay for pain management. You try to do bypass. Always put pain management as the last option. So I don't think not like no surgery pain management. No. So this will be given as a last option. Spinal stimulator, I don't know what is that, but I don't think this will work. I know if it's Ali, you know about it, but I don't think this works,
Samer, we used to put the spinal cord electrostimulation. It was of the Medtronic in cases of non-surgical vasculopathy, peripheral vasculopathy, and it gave good results. So I don't know if in these cases it would give some result in this case or not. It's called spinal cord electrostimulation. They are like pacemakers that you put under the skin and you can regulate them from outside by a remote control. So you know them.
No, I
They are
never.
of
Yeah,
Medtronic.
I saw them, but
So
for
I don't know.
lumbar, but I never saw them in the neck or for thoracic outlet. I saw them
In lumbar, yeah, lumbar. Yeah.
I saw. Yeah,
In lumbar,
yeah.
right.
But in
I
the
don't
upper.
know if we can use them in these cases or not. No, so.
Okay, let's see what the other option. Let's go next one.
Yeah.
Referral for anterior scalene lidocaine injection. Also, this is it will give only temporary pain relief.
Correct.
So I don't think it's the best option.
Okay.
Referral for botulinum toxin injection of anterior scalene.
Buttocks is a muscle, right? That's why you use a buttocks. And usually buttocks stay for 6 months. Usually, and you do any buttocks injection. So I think it's a good option. I mean, it's like lidocaine only for a couple of minutes or hours, whereas buttocks it works for a couple of months. So this is not a bad option. What next one?
6-week trial of corticosteroid therapy. Also, it's not a bad option. It's good.
Yeah, but
I'm not sure it will help or not.
Cortisone. See, the problem here is anatomical, Bassam. It's not inflammations.
Yeah.
When you take a buttocks, not because of inflammation, because you want the muscle to relax. So you need a compression on because anatomical compression. So you want the muscle to relax, so it decreases the compression. So corticosteroid, it works only if you have inflammations, So I don't think this will work, or not the best option,
Yeah. Radio frequency ablation. We don't have actually any idea about it. Like so C is
the best options. Yeah, I think some people they do that. They give buttocks because now giving buttocks everywhere, like for inner fissure, sometimes give buttocks to release the muscle. So buttocks, buttocks injection is very helpful. You can inject spasm. So one of them
it will relax the muscles.
Yes,
like achalasia also.
Yes, and it lasts for a long time. So this is not a bad options. Even sometimes you can use a diagnostic, to see if he improve with a buttocks injection. Again, lidocaine also it works, but the only problem is lidocaine is shorter, so buttocks is longer. It's only different. Spinal stimulator, I don't think will work, and corticosteroid radio frequency will not work. Okay. For the spinal, I'm not sure, but I don't think so. Spinal cord stimulator is an important device that provides a pulse, low voltage electrical energy and epidural space near the spinal of concern. Evidence does not adequately support spinal compression as a primary treatment of neurological TOS. So as Ali said, it works, but not in this scenario, okay? All right, let's go to the next one. Who else with us here today? We have Zahra, we have Maitham. Maitham, you want to take this one?
Yes, okay.
Maitham?
Yes.
Okay.
This patient in this image will mostly commonly present with. So
this is here. She's arterial. What do you see here? You see a cervical rib?
Yeah, there is a cervical rib and it's compressing on.
And
there is an area of compression.
And what after compression you have here? You have dilatation.
Post dilatation, yeah.
So post, compression dilatation. Okay. What the question the patient image will most commonly present with? So what do you think he will present? So it's arterial TOS. So what the most common sign or symptom of arterial TOS?
Usually it's ischemia, pain, ischemic pain.
Embolization, correct? And
yeah.
So let's see what they give you.
So A, left arm edema. B, left supraclavicular tenderness. C, left arm pain in the ulnar distribution. D, left arm ischemia with possible emboli. This is most likely the answer. E, posterior stroke.
Okay.
So I think the answer is straightforward. D, I think.
What, left arm edema is what?
This is venous, mainly venous TOS.
Supraclavicular tenderness is what?
DVT, you mean?
No, neurological. Supraclavicular tenderness when you inject.
Supraclavicular. Okay, I thought left arm edema.
Yeah.
Yeah.
Pain in the ulnar distribution also neurological. Okay.
Mhm.
What about posterior stroke? Could happen, but it's rare.
I have no idea about this. Yeah.
Because you can retrograde embolization because get emboli here. Sometimes you can get retroembolization to the vertebral artery and you get a posterior stroke. So it's possible, but it's rare. The most common is to get an arm ischemia. Okay. But posterior stroke, it is one of that, but again, it is rare. So it's not the most common. Okay.
Very rare.
Yeah, but it's there. That was they said most commonly presented. They said commonly, so they want to know what the common. But if they not say commonly, it's one of them. Yeah, but it's very rare. Yes, I agree. All right, who else, guys? Zahra, you want Zahra?
Yes, Doctor.
Okay, Zahra, let's take number 5.
Okay. An 18-year-old man is referred for consideration of for thoracic outlet decompression surgery. The patient is active in his school baseball team. Prior to proceeding with surgical intervention, the characteristic that is valuable in predicting a positive surgical outcome is?
Okay, so this patient, he had thoracic outlet. He won't go for surgery. So want to know, predict positive. Because why is saying that? Because as I said, you can do a surgery, patient still have a symptoms, correct?
Yes.
So none of them, they improve after surgery. And this is very important to tell the patient ahead of time, guys. Don't, this is very important because they, oh, I didn't improve from surgery. So always tells the patient is about, I think, 40% chance they may not improve. So it's improvement only 60%. So it's very important before putting him through a surgery and then come say, oh, I didn't improve, So what I'm telling you what's this one can give you a good prediction that your patient will improve from surgery, okay? And this is the options, Let's go through of them.
A, accurate identification of a nerve root involvement using EMG. B, venogram demonstrating partial or complete axillary subclavian compression with arm elevation. Diminished wrist pulse with arm elevation or with provocative maneuvers involving shoulder abduction. MRI demonstrating musculofacial variation in the scalene triangle. Lidocaine injection in the anterior scalene muscle.
Okay, let's go through one by one, okay? Identification of nerve root involvement using EMG. It's nothing to help you with this, with a reduction what's going to happen after surgery, right? This is to help you during the surgery to find the nerve, right?
Yeah.
So to know exactly which nerve compressed, not compressed, is not really it help. As I said, EMG really doesn't help much in the thoracic outlet, and now we don't order it anymore. Okay. Venogram. This is to do with the venous, right?
Yeah.
Not surgical, so it's nothing to do with that. I mentioned pulse. This is to do with arterial, right? So it's nothing to do with the neurological side. So this is two by itself, they will be excluded, even before continue reading what's inside. MRA to see the musculofacial variation in the scalenus triangle. You already have a muscle debris, you have a narrowing, it's a narrowing. So MRI will not tell you much because you can cut all this muscle. The question you want to know, if I cut this muscle, is patient going to improve or not, So you want medically to cut this nerve, this muscle. So how you can medically before do a surgery?
Local anesthesia, lidocaine.
Lidocaine injection, see? If you see improvement, then, but it doesn't mean that if you don't see improvement, you don't do it, Still, you can do it because it's not 100% accurate, but it's just give you an impression that muscle elevation will improve from that, because compression not only come from scalenus muscle, come again from the first rib, from fibers, from cervical rib, but it help you to make diagnosis that muscle elevation will benefit from that. But if you cannot say I did a lidocaine injection and patient did not help, then I am not doing decompression. If patient is symptomatic, of course, If you're not sure about the symptom, then you do it, and then negative, then I will not do thoracic outlet. But if I'm sure patient has thoracic outlet from symptoms, I just do this one just to help me to predict the prognosis, okay? And this is easy to do, really. It's not difficult. Any question? No.
No, it's clear.
All right, let's go to the next one. Today, all thoracic outlet looks. This is all about extremities, all thoracic outlet. But this is important, right? You see it here. It is, you see it in the. How often do you see it, Ali, thoracic outlet? You see a lot?
We see a lot. No, I don't know. And this year I did 3 young patients, 2 females and 1 male, young, about 17 years, 18 years, 20 years. One of them was a musicist. She plays violin, so she had symptoms. The other had a non-complete cervical rib, but with a tendon that was communicating the cervical rib to the first rib, taking up all the anatomy, dislocating all the artery and the vein and the plexus. So I don't know. This year 3 patients I saw.
Neurological or arterial or venous? Or neurological?
Neurological and 1 arterial, but she didn't have any post-stenotic aneurysm. So they were neurological.
Okay, so neurological, okay. All right.
But symptomatic, yeah.
Okay. All right, let's go to number 6. Who's there? Go back to you, Ahmed.
Okay. The physical examination maneuver most helpful in helping to diagnose arterial thoracic outlet syndrome is A.
Okay, go ahead.
Upper extremity pulse volume recordings and arterial Doplex.
Okay.
It sounds good. B. Elevated arm stress test. This is for a neurogenic.
Okay.
Upper extremity venous Doplex. This is for venous type.
Okay.
EMG for neurogenic again, and MRI also for neurogenic. I believe A is the answer. Plus, these are investigations rather than physical examination maneuver. So A.
How can it help you to make diagnosis of arterial duplex? How's it going to help you diagnosis? I mean, you do arterial duplex. What are you looking for to help you in diagnosis?
Stenosis, increase in flow, distal to the compression, the aneurysm appearance.
Mainly looking for the aneurysm because, again, when you have an arterial, majority they have aneurysmal dilatation. Because just to see compression, as we said before, it could be a normal, variation. So it's nothing in medicine like 100%, but 90% you have to have dilatation or aneurysm to make a diagnosis of arterial thoracic outlet syndrome. Because if it's just the physical exam is not correct, So, or if he has an emboli or occlusion artery or something like that, so he's emboli, then you make a diagnosis. So emboli or aneurysm make a diagnosis for arterial thoracic outlet syndrome. The reason why arterial duplex is very important to look at that, All right.
Okay.
So this is the way, as I said, arterial is easier and venous to make a diagnosis than neurological because you have something you can rely on it. You can see. But if I do like patient, and come and the flow is normal, no aneurysm dilatation, just the pulse disappear when you lift the arm, this is not arterial, thoracic outlet. Okay.
But the question is asking about physical examination maneuver, and this is an imaging. I don't know.
The physical examination maneuver, you're right. This is wrong. You're right. The examination maneuver most helpful in helping. But then give us any so elevated arm stress test. Upper extremity venous, no. EMG, no. MRI is no. I mean, yes, it's a physical examination, but elevated arm stress test. But this stress test for neurological also.
Neurogenic, yes.
So I think the answer is, it's a question. Hold on. Remember, guys, who put the question are physicians, so they can be wrong. And it's not like, you're right. This is not, but all of this option, I think A is the best option, But you're right. All right, Muhammad.
Perfect, sir.
Volume recording, yeah. Let's go to 71. 7.
Yeah. A 21 years old male lacrosse player presents to the emergency department with numbness, tingling, and edema of his right arm. He has swollen right arm with intact pulses. An ultrasound revealed acute DVT in the right upper extremity. The most likely diagnosis is.
Okay. So he's, you know what, lacrosse player? This is, I don't know, it's like a very weird, you know, game. It's like a stick, basket at the end of it. I don't know if you know, long stick, like a golf, and has a basket. They capture the ball with this basket and they, you know, shovel it away.
Okay. Yeah, I saw it once. It's an Indian game and American, I think, Australia play it like cricket.
Like cricket. One has a basket, catch the ball with, like baseball, but instead of the hand, use a long stick. It's very close to baseball, I think. Yeah. All right. So patient came with DVT.
Yeah.
And he's a young guy, 20 years. He's a player, so he's using arm a lot. Edema, swelling. All right. So what diagnosis? What options they give us?
They give us catheter-associated DVT. No, not related to the question. DVT due to venous compression by cervical rib.
Okay.
They didn't mention it. They didn't mention that he had cervical rib in the question. C, Boland syndrome. I heard about it, but I couldn't remember. And D, superficial thrombophlebitis. E, venous thoracic outlet syndrome. I will go with E.
Venous thoracic outlet syndrome.
Yeah.
How different B from E?
Because they didn't put it in the question. Yani,
okay. But it
they
doesn't
didn't mention that he had. Yeah.
No
chest X-ray, nothing in the exam.
Okay, this 2 4 yes. I mean, you're correct. I mean, they mentioned the first. Second thing, cervical rib rarely use a DVT, venous. Remember?
Yeah.
Remember when we did, you know, thoracic outlet decompression? Where is the vein? Vein is very.
Venous is very inferior, and the cervical rib usually superior. Yeah.
Cervical rib most probably give you a neurological, and second thing, arterial. But venous is very, very rare to give you because it's far, you know, in the back. You know, mostly the nerve is compressed between the muscle and you know, the thoracic inlet. You know, so this is compressed. So cervical rib is not common with the venous thoracic outlet. You know, so it's important to know that. So venous thoracic, but it's a bad question because venous thoracic outlet syndrome and DVT due to venous compression, it's very similar. But I would choose E. You're right. You know, for 2 reasons. Poland syndrome is the one where you have like I think weakness in the muscle part of half of your body. It's a very rare syndrome. You know, like you see atrophy in the muscles. You know, so it's against opposite to the thoracic outlet. Thoracic outlet is hypertrophy of the muscle. Poland is hypertrophic muscles, you know.
Hypertrophy or absence of pectoralis major and minor.
Like that. Yes, you see the muscle deviation, like some muscle, like hypertrophic, some is high, you know. So it's very rare. I never saw it, but anyway, yeah. So the venous thoracic outlet syndrome. Okay, it was not a good question. Let's go to Vasam. Vasam. Yes. Let's see if you can get a good question. Number 9.
A 19-year-old right-handed hairdresser presents to the emergency department with painful swollen right arm. The patient reports several months of exertional heaviness with the arm. She is noted to have developed large varicosities on her upper arm. She was placed on anticoagulation. Venography demonstrates total occlusion of the subclavian vein, occluded collaterals, a patent internal jugular vein, and a patent superior vena cava. Attempted passage of a wire across the lesion is technically unsuccessful. The next reasonable management option is. So he's talking about a young girl with total occlusion of subclavian vein
but she has
with
no.
patent internal jugular vein and superior vena cava.
Okay.
Failed endovascular recanalization.
Correct.
The next option will be, okay, let's go through the options.
Okay.
Balloon angioplasty of the subclavian vein. They failed to pass the wire, so technically it's difficult.
Correct.
Bypass to superior vena cava or jugular vein. So it seems, according to the informations in the question, that this is the answer.
Okay.
Patch angioplasty of the subclavian vein. It's not enough because if total occlusion with multiple collaterals, it will be difficult, and the vein thrombosis or DVT will be like fibrotic, so it's difficult to do patch angioplasty. Stenting of the subclavian vein, it's not an option because they failed to pass the wire. Thrombolysis, it's not an option. So the answer will be B.
All right, because she has a chronic, okay? It's not an acute, okay? Right? Let me see, several months, okay? Heaviness arm, she's not to have developed large velocity. So it's including occlusion being there several months, okay? It's not like acute. Okay, now she has viscosity. So if it's an acute, then thrombolysis is an option, but here is not an option. Second thing, they try to pass out, tell you that's a chronic. If it's an acute, then wire will pass easy. But this second also sign tell you it's not an acute. So we talk about chronic occlusion. And as you said, when you have chronic occlusion, it's different because chronic occlusion is you have a fibrosis. So you cannot do patch angioplasty, you know, you cannot do anything. So second thing, we don't know what diagnosis could be thoracic outlet. We're not sure, you know, especially a young person. You know. So balloon angioplasty, again, you cannot pass the wire, so you cannot do it. You know, standing the same. Bypass, I think this is the best option here, but I don't know if I will do it in young people like that. Mostly my team will be conservative. But they said here because internal jugular vein is open and superior vena cava is open, you can do bypass from, you know, from maybe exerty to the interjugular vein. But the question, what going to use saphenous vein? Small, you know, it's a problem. It's no problem with the venous, you know. We use saphenous vein. What is saphenous vein? How big is a saphenous vein? Like 5-6 millimeters. So I don't know how help, you know.
And venous bypass, it will not.
So and you've used
stay for a long time without a fistula.
As a question, this is the best answer, but in real life, most about you conservative, you know. Ali, what do you think, Ali?
I agree with you, conservative. It's better in these cases in real life,
Because
but you mentioned all collaterals occluded.
Yeah, that's why she has a swelling. So that means the reason why you have to give us some time if she does collaterals. As I said, as a scenario, I mean, this is, but in real life, because if you do a bypass using a vein, I mean, I don't think this would work very well, you know. But unless if like something really, you know, because I'm sure with the conservative management and this one, she will develop collateral later on. So will not be my next step. So again, as for the exam, this will be your answer, but in real life, I'll try to be conservative as much as I can, okay? All right. See if they said anything. It's a challenging situation of cancer, acute on chronic, become damage from repeated, stenting's not, vein excluded, it's not a work. Of the option presented, a venous bypass is reasonable given the patient. See, of the option presented, يعني الoption أعطوك أنا أحسن شيء بس معناتها this is the right treatment, okay? See what they said, of the option presented, you know. Anyway, it's like just an exam question. It's not a real life scenario. All right, we go back to who else we have here. We go to Zahra again. Zahra, you want to do number 9?
Okay, Dr. A 36-year-old woman presents to the emergency department with left arm edema, numbness, and tingling. She is right-handed and was painting her ceiling for most of the previous day. On examination, she is neurologically intact with an edematous left arm. A duplex reveals acute left upper extremity DVT. The most appropriate first next step is compression sleeve, no. Percutaneous thrombectomy with stenting, no. Systemic anticoagulation, yes. Thrombolysis, we can start it after anticoagulation, but it's a next step, so we will start anticoagulation immediately. Thoracic outlet decompression with thrombectomy. Also, thoracic outlet, it's an option, but after the anticoagulation.
So where's the key in this question?
The first next step, the most appropriate first next step.
Is it the first?
Yes.
That what the most appropriate step then will not be anticoagulant, okay? Will be thrombolysis. She's young, right? She's 36 years old. She has an acute thrombosis, right? So the most appropriate really treatment for her is thrombolysis, okay? And then the decompression. But because that the first next step, of course, when patient comes DVT, first thing you start with anticoagulant, right? Then you consider thrombolysis. Then after that, you can do ballooning, or we have to do a decompression, you know. So you have to be, guys, careful what the question is. So I agree with you. If they said first step will be anticoagulant, but if they said what the most appropriate step or treatment will be thrombolysis, okay?
So here it's thrombolysis? So you mean in this question it's thrombolysis?
No, your answer correct, systemic anticoagulant. Because it's first next step, you see they said first.
Yes.
When they said first, yes, when patient come DVT, the first thing you do, you start on anticoagulant, correct?
Correct.
Don't do thrombolysis before give anticoagulant. First anticoagulant, right? So the first step is anticoagulant. Next, you consider thrombolysis and all the things. But I'm saying if they don't say first step, if they said what the most appropriate treatment, then your answer will be thrombolysis. But because they said first, next step, then our answer will be systemic anticoagulant. Okay?
Okay.
All right. Let's go back to Maitham.
Yes, doctor.
Let me see. Sorry. Take the question after that. Systemic anticoagulation. Sorry, sometimes computer just freeze. Here we are, 13. No, I went too far. Very sorry, guys. Where are we now? Should be 10, right? Sorry, too many orders. Just that thing cool down. You just close it and open it back again. Sorry, guys. Do you see it again?
Yes, doctor.
Yes, we do, doctor.
I'm just trying to figure out because it went crazy. So we did number 9, so now it should be number 10, correct?
Yes.
Okay. Come on. Sorry, guys, just take forever. Okay. Stop, please. Okay, here we are. Now, number 10. All right. Okay, finally. Okay, Nathan, go ahead.
21-year-old right-handed man present to the emergency department with a painful swollen right arm for 6 hours. He is neurologically intact with an acute right upper extremity deep venous thrombosis on ultrasound. He had a CT venogram that confirmed the DVT extending approximately to the level of his first step. The patient has been started on therapeutic anticoagulation. The most appropriate next step is, so patient have acute DVT 6 hours, and he was started on therapeutic anticoagulation. The next step, elevation of the evaluation for thrombolysis. I think it's a valid option. Yes. Open thrombectomy. It will be not next step. Percutaneous thrombectomy with the stenting. Also option. Systemic anticoagulation, already started on therapeutic anticoagulation. Thoracic outlet decompression, this is definitive management. So given the acuteness of this situation and his age, I think thrombolysis is an option in this case. Next step after anticoagulation.
Why not open thrombectomy?
Open thrombectomy.
Is it possible?
Well, it's proximally extending to the level of the first strip. It's
open no, I mean, it is an option, but if you have thrombolysis, why should do thrombectomy? But if you are in an area you don't have thrombolysis, you don't have, you are not access to the endovascular, you don't have endovascular skills, then open thrombectomy is an option. So it's not out of the table, but it's not the most common because now thrombolysis is very common. But like you say, you are in a rural area, you don't have or let's say patient has like a recent surgery, has like a lower GI bleed, you can do thrombolysis, then do thrombectomy. So the most important, we have to get the clot out. He's a young guy, So,
yes.
So 21. See, evaluation for thrombolysis, because sometimes they cannot do thrombolysis because he's bleeding or recent surgery or whatever, or trauma. So, but if you cannot, you don't say, okay, I cannot do. No, thrombectomy, it can still be done, open thrombectomy. It's very simple. You just go and you do thrombectomy, okay? Pectans thrombectomy and stenting is not a good option because this patient most probably had thoracic outlet. So if you put outlet, then you fracture. So we don't do thoracic outlet unless after you decompress, then you do stenting. Yes, sometimes we do stenting, but after we decompress the thoracic outlet, because the venous injury in the thoracic outlet is very long, and sometimes it's very hard to fix it all in surgery. So sometimes you do like hybrid. We do surgery decompression, and then we do part with the stenting, But you have to decompress first, okay? Systemic anticoagulant, we talk about it, you're already on it. And thoracic outlet decompression, this will be definite surgery later on, but not now, okay? So patient comes with the DVTs, anticoagulant, thrombolysis, then if he has thoracic, then you do a thoracic outlet, okay? But this is the way we treat them. All right, so we go back to you, Ahmed. How much time still left? Let me see. You can keep going. Yeah, we still have
yes, please.
I love it. Just keep going. You have 10 minutes. Okay. Go ahead.
Not yet. Okay. A 25-year-old professional baseball pitcher presents at the end of the season with acute swelling of the left arm dominance in this patient. Duplex demonstrates axillo-subclavian DVT. He undergoes thrombolysis at another institution with resolution of the thrombus, but severe stenosis of the vein. Venoplasty at the time demonstrated fibrotic vein. He was placed on anticoagulation and advised to follow up with vascular surgeon in the next week for definitive surgery. You decided to perform open vein reconstruction after discussion from the referring surgeon. The best approach to surgical repair in addition to perform venolysis is?
Okay, so this patient, he came, you see, guys, they give you a scenario one by one. First, they started with anticoagulant. Second question was thrombolysis. Now this question, surgery, you see? Because it's the way you should treat this patient, you know? So now we come to surgery. So the question now, how you do a surgery? This is the whole question. So patient has a DVT, the thrombolysis, you open the vein still, I mean, it's open, but it's like fibrotic, but not fibrotic, it's just severe narrowing stenosis, long stenosis. So how you do a surgery? What the options, you know? Let's see what options they give to you and see, we go one by one.
A, transaxillary approach,
Okay.
interposition vein bypass with PTFE.
Okay.
And this is a bit difficult approach to reach the subclavian vein.
Okay.
B, infraclavicular approach, interposition vein bypass with reversed saphenous vein.
Okay.
I don't know about the saphenous vein, if great to reconstruct subclavian vein.
Correct, it's too small.
Transaxillary approach, interposition of vein bypass with reverse saphenous vein.
Okay.
Same problem. Paraclavicular approach, patch repair of vein with a junctive stent if needed. What's the meaning of paraclavicular? Supra or infra?
And both. Supra and infraclavicular, you do both.
Okay, it seems good.
You
But
did-
let me see.
I think the first patient we did, Dr. Amran did here.
Yes,
With-
up, above, and below, but it was not for venous, it was for arterial.
Yeah, but he did it's called paraclavicular.
Yes.
But this
Yes.
patient, yeah. So this is what he called paraclavicular approach. Okay, go ahead.
And E, supraclavicular approach, patch repair of vein with adjunctive stent if needed. I think stent in this location is liable for fractures.
Okay. And
So
several small.
D is better.
It's far, huh?
D,
But you said stent is not good. You just said stent is not good.
yeah. Is
So-
it liable for fractures at this location?
F. Should put F. Well,
Yeah.
well, I tell you, it's not, I mean, like, you have no ideas, right? So try to figure it out, you know. First, when you have a venous DVT or venous stenosis, it usually is a long stenosis, not a short stenosis, different from the arterial. Arterial is like you see small, see vein, you see usually long stenosis, you know. You never see like vein like one area, right? Always when you do a venous, always you see the whole vein is, so venous different from the arterial. So always you have a long stenosis. So one approach, no way you can get it from transaxial or supraclavicular or infraclavicular. So one approach, no way you can get the whole vein, you know. So this is one thing you have to think about it. So if transaxial is too far, you cannot get the venous to repair it. Infraclavicular is too short because you have supraclavicular area. So most of you have to do two. But then, okay, you expose the vein. What are you going to do? You got interposition vein graft. What vein are you going to use? Saphenous vein is too small, unless you take a femoral vein, which is not mentioned here. So really, the most important in these areas is to do venoplasty. You put a patch. You open the vein and put a patch. You know, you're not to solve the whole problem because you still have an area proximal distal stenosis. Because through this option, because like I said, the vein usually go more distal and more proximal. So most of the time you end putting a stent later on. And there's no problem now with a stent because you decompress the thoracic outlet now. It's different, you see. Even some people, they do a hybrid. So what happened, they decompress the muscle and, you know, and then they go and put stent, you know, for the vein because it's better. So the best option is to go with the D, to go paraclavicular. You do patch to the vein because you cannot put interposition, you can't put PTFE, it's not good, and saphenous vein is small. Put a patch, and then whatever stenosis, then you do compression venogram. If any area stenosis there, you can put a stent there. Or you can do the whole, you do just paraclavicular approach, cut the muscle, and go in the vascular and do stent. So most of it, you end with a hybrid with the venous, not a simple like an arterial. Okay? So this is the way we approach the venous DVTs or thoracic venous, because you're not like an arterial, one area you just cut it and you'll be fine. No, because the whole vein is thrombosed now to have long fibrosis because of DVTs, you know, and usually it's a long injuries, you know, in the veins. So harder to do like a small area. You can cut and put them together like an arterial. You cannot do that with the venous. Okay.
Do we have to reverse really saphenous vein and vein reconstruction if used?
It's a good questions. Not really, no, because the vein, you're right. You should not reverse it. It's a good thing also. They reverse the vein here, should not reverse it, yeah.
Okay.
I mean, it depends what you mention by reverse, because the vein, proximal is the opposite. So proximal, I don't know. I mean, you cannot, Ali, what do you think, Ali? Do you have to add anything?
We don't reverse the vein in the upper limbs. We don't reverse the vein in the upper limbs exactly. We don't reverse it because the valves have the same direction of the flow. So we don't reverse. Usually I use the supra and infraclavicular approach in these cases to decompress well the outlet syndrome. So regarding using the stent or not, I agree with you, but I use the supra and infraclavicular axis in these cases. And if you have to use the vein, you don't have to reverse it. You have to put it like that in the same direction as it.
Or you can cut it and use it as a patch. I think it's the best way. You can get the vein, cut it long
Or
together.
you use it like patch, or use like patch if you want.
All right, we already 9 o'clock.
Or you can reconstruct a vein with larger diameter if you want.
Use the femoral vein.
Like when we do with you can reconstruct the vein in the way that we use it to increase its diameter if you want.
Yeah, like a spiral graft. Spiral graft.
Yeah, like a spiral reconstruction. In these cases, I think they intend in these cases the use of the vein in these cases to reconstruct it, to resuture it, and to use it like this to make it with a fit diameter.
That's true.
For this reason, they mention the vein usually.
Yeah. All right, I think we're done, guys, today. Well, it was a nice session, really. I thought it'd be boring, but it's not too bad. Okay, all about thoracic outlet. All right, guys, we'll see you next week, okay? Enjoy the rest of the night.
Thank you, Dr. Samer. Thank you.
Thank you, Doctor. See you tomorrow.
Good night.
Thank you, Dr. Samer.
Good night.